Some of the ideas of going into a state have been to go into states where you understand that there are physician and NP and physician nurse practitioner collaborations available, or where you are recruiting others, that they have those relationships in place. You may also want to develop relationships with multi-specialty groups or with hospitalist organizations in terms of hospital admissions, and also for the opportunities to participate in transition care management opportunities from the hospital out to the community. And these relationships would also give you the opportunity to have the home health agency orders issues covered, as well as the admission issues, and also any prescription issues, again, on a state-by-state basis. Also with the multi-specialty groups or group practices, that also may provide access to health plan relationships where they've wanted a fixed office or are only contracting with MD practices. Again, you also want to market and make yourself known to those health systems and physician-led accountable care organizations that are in your communities and in your states. There's an increasing understanding of the power of house calls, and this will be discussed at the annual meeting, and the savings, the care and the savings and satisfaction you can provide to the home limited and the expensive cohort of patients that are in ACO panels. And again, there'll be more information about those outcomes, the data provided at the annual meeting. So do hope to see you in a couple of months. And some of you, we are getting some of your suggestions and questions coming in now. And as that's occurring, in terms of business planning, pro forma development on the revenue side, as mentioned earlier, one of the areas you have to look at is the patient demographics and payer source. We talked about Medicare, but you also want to look into the private fee schedules. You want to look at other coverage and payment relationships, and understand there's going to be patient payments both for any self-pay services and patient co-pays. And some of the opportunities described, and we'll talk about those a little bit more in a moment, may also provide the opportunity to contract directly with a health plan or with a hospital for some transition care management payments that may be improvements over just a base fee schedule approach. In terms of expenses, again, as you go into an area or expand your practice, you need to have a strong understanding of your working capital to include your practice, the business functions and the infrastructure required, the revenue cycle requirements, scheduling, and other assistance, costs for, again, those professional relationships and collaboration agreements. And then as we are working on your behalf, and as you also know, and we will talk more also at the annual meeting, standards-based requirements as new codes develop and new payment models evolve that require some sort of practice certification along the lines of what's known as the patient-centered medical home. We are working to make that applicable to house calls, or to make sure that the standards that are developed provide a recognition for your practice settings and the benefits that it provides. But it is going to have requirements. They are going to include requirements in those standards, and so that has to be included and considered from an expense perspective. And then finally, as you're developing your business plans and expansions, the compensation of other professionals and your own compensation, how much was going to be available after those expenses are counted, And then while your compensation is a bit of a safety valve, while things are getting up and running on an ongoing basis, you do want to make sure that whatever opportunities that are there for you, particularly in independent practice, are such that you pay yourself on a reasonable basis that you want to keep going. And that if not, there are those other opportunities for you if your environment's not one that's more vital and robust for independent practice. So how will you be paid in the future? Right now we're working off the traditional Medicare fee schedule, and as we see with the SDR discussions, that's getting more restricted over time. The Academy is working and on new codes and evolving payment models that include chronic care management services. Over the past years, the transition care management codes came into effect, and some of those of you on this call are making use of those codes. The chronic care management code services have been surveyed or are getting under review by the AMA process now for inclusion in the payment rule this year for payment effective 2015. Also, there are the shared savings and fixed payment systems, both from a Medicare perspective and increasingly in the private health plan community as well. Okay, in health plans and health systems, some of you are aware of the availability to provide assessments on a per assessment or on a more organized basis. Also to have the transition care management services paid. We do have examples of that across the country, and those contractual agreements in place, and those are growing, and we can assist you with those relationships. There'll be more discussion at the annual meeting, and there'll be a webinar toward the end of the year on developing those relationships with health plans and health systems for your services. And again, how to package the information and the benefits of your services. So again, an open question here is what are we missing? And again, please feel free to send in what you're finding in your communities. The strengths of NP and PA in practice, we know is found in team care, in both practice and the literature, and in team care, screening and preventive services, managing chronic conditions, provides for patient and caregiver satisfaction. Your services provide access to patients and availability. This is the case not only on a 24/7 basis, and this is increasingly going to be required both in the standards that are coming along for coverage of the new codes and in the shared savings models, but you're also available across the country in areas where there's a greater shortage and need for primary care providers. Do make use of this and understand that you provide a high level of value to your patients, to your community, and to your referral services. So while there may be obstacles to practice, while you're in discussions with physicians, with health plans, with facilities, with home health agencies, et cetera, you are also a source of the professional services, the patient care, and the clinical and the financial relationship that flows both directions. So do be aware of the value that you provide when you're in those discussions as well, and not to be bashful. Okay, I'm going to turn things over for Constance Rao, the Executive Director of the Academy, to go over some of the materials that you have sent in to Overcoming Obstacles.
Gary and I are absolutely sure that among you there are answers to everything you're going to ask. And let me just give you some examples from the things that have been sent in so far. And we hope very much that you'll continue the conversation at your very own 7 a.m. wake-up sessions at the annual meeting and through the listserv and just in talking to each other. But let me give you some examples. One person says, I'm having trouble getting physicians in the office to sign orders after they're reviewed by the NPs. They say we're working with a company called SutureSign that does this electronically, and it's been wonderful. We have no more paper 485s. Everything is electronic. Turnaround is quicker, and it's easy to monitor what is outstanding. CPO billing is also so electronic is one answer. Another answer is not getting another obstacle is not getting referrals. The person writes back, we work to have excellent patient outcomes and to reduce readmissions, especially in the CHF population. As they learn, as the doctors learn how we can help them and their patients, their referrals continue to increase. By the way, we've heard that one from lots of people. It's developing those relationships. Another one, what to do about an environment that seems to only offer non-friendly MDs. In some cases, people have literally had to go and find them because they do exist, and be selective, not just take whoever is the first person who comes along, because having that relationship, especially in states where collaboration agreements are required, is in fact essential to an effective practice. The last example is someone who says, I have multiple geriatric partners. I work in a SNF. The question is, who is my delegating physician when I work fairly independently? The answer that we've heard from lots of people is written agreements, something that you would generate that people would then be willing to sign on to. It can have one signature. It can have multiple. It's sort of like a standing order, except that this is like a standing delegation. So here are just a few examples. I'm sure that if you kept going, you all would come up with lots more things. But this is just a few examples to get your thinking going. And here's another one. Okay, okay. Okay, I can answer this one. Do you want me to? Okay, this is not challenges and opportunities, but I'll just answer this as a general answer. What are the opportunities for NPs and PAs in the Independence at Home demos? The answer are lots. One of the models is an all-NP model. Another one is an NP and PA model itself with some collaborating physician agreements. Most of the practices that are running IAH at this point are operating in teams, and the teams almost always include either NPs or PAs and sometimes both. So those of you who are interested in the Independence at Home model should certainly take a look at the evolving evidence based on that score. We are going to be featuring some stories about some of them in upcoming newsletters for those of you who are interested. Gary, maybe you can give an answer to this one. Give it examples of standards-based requirements. Yeah, okay, I'm going to turn it back over to Gary.
Getting back to the IAH and the shared savings models for a moment, and then I'll get back to this question. The Academy worked to have nurse practitioners and physician assistants written into that language, and that's actually something I'll get to at the end of this afternoon's presentation as well. And that we also work on as other shared savings models come along and standards development, we work to the greatest extent that we can to make sure that those opportunities for nurse practitioner and physician assistant involvement are there. We would also encourage you to have strong relationships with physicians in your community as those opportunities develop, both on a federal or public level and also on a private plan level. as it's often going to be in the team-based care and shared aggregate relationships where opportunities that align the financing and care are growing and coming along. In terms of some broad categories of what's meant by standards, standards development includes issues such as access to care, and when is patient access to care or access to advice available. In one of the organizations that certifies for what's called the Patient-Centered Medical Home, they've just come out with 2014 standards to replace 2011 standards, and the 24-hour access area is being emphasized, and again, we believe that's an area of strength for house calls. Team-based care is one of the standards areas, and again, each of these has multiple elements underneath. Population health management, care management and support, care coordination and care transitions, performance measurement, and quality improvement. And again, many of these areas have aspects, the care management and support, for example, of patient assessments, evaluations, patient preferences that we believe are strengths to that house calls provides, and also in the area of performance measurement and quality improvement. So we will provide more information about what's the general framework of standards throughout the year, and also as we work with CMS as they develop standards for the chronic care management codes going forward. Again, that brings us back to how you'll be paid in the future. What the strengths of your practices are. Okay, and now where we go from here. There's a need for your involvement in terms of national and state advocacy. The slide at the end will include a reference to the Association of PAs and also the American Association of Nurse Practitioners. And then that includes, again, the need for your involvement. We can help on a broad national basis, as I mentioned, with the shared savings programs and programs such as IEH. We don't have the opportunity or the ability to or the benefits that you have to be in the states and to speak to your local representatives and go to your state capitals as you can. Some tips in terms of state and federal advocacy that have come from the professional associations. And while this is written from a state perspective, one can also apply this on a federal level when you're speaking with your representatives to Congress. You want to link research to the specifics of the state or to the area of the state in which the representative represents, such as the quality of care, access to care, and outcomes for that patient population. You want to link changes to improve patient access and quality that you can provide through your services, and that's why they need to be made available and paid. You want to focus government officials and policymakers priorities toward modernizing state practice acts, such as those we reviewed earlier, to enhance your scope of practice. You want to educate the public as to these issues. You want to inform policymakers about research findings. And as Connie's mentioned on this call, and as I did, we have additional information that's coming out that'll be available at the time of the annual meeting, and then any findings that are provided to us, we also will post on the site and make known. You want to create awards and recognition strategies for those supporting your NP and PA practice, and that support patient access to qualified, safe healthcare providers. And so you want to recognize those that are supporting the profession in practice. You want to summarize and distribute relevant research, including any comparative information about your state or, again, about your district as compared to others, with some action lists and recommendations to the state legislators. And again, this would be also the case to your federal representatives. And you would include references to the vision papers and to the model legislation as we described earlier in the webinar. And again, that it's will be available through links on the slides that are posted. And then you want to invite media and policymakers for ride-alongs, and we know that this is effective. We have heard from those of you across the country that when this occurs, this is really an eye-opening experience and gives a great appreciation for your services and for the benefits it provides to patients and to caregivers. Again, just to wrap up, what are some of the things we're doing and what can we do? As you know, to recognize your services and your involvement and the importance of your services and your involvement with the Academy. The Academy name change is official. We are now the American Academy of Home Care Medicine. That will be celebrated in May in Orlando at the annual meeting. And again, hope you're there to join in that celebration. We provide legislative and regulatory support. Again, we can do this on a national basis and on a broad basis. We support issues such as your ability to order home health services, research, et cetera. And again, this is done on a national basis, and we can provide some broad policy support or generalized support on a state level. We just can't be there in each state with you, but we can provide as much background material as we have available in capacity. We provide, again, the support in terms of code and model development that the services of nurse practitioners and physician assistants are included and also paid. Again, that goes to support team-based care in the federal and state programs, such as was mentioned in terms of independence at home and other shared savings models. And then, as we were just talking about, the standards development that supports house call practice. That's, again, an area of attention that we want to support the practice and the identification and recognition of the involvement of nurse practitioners, physician assistants, and others. And then following in the list are the other resources that are available through the Academy on an ongoing basis. Here are some of the resources that have been referenced during the webinar. Links to the American Association of Nurse Practitioners, to physician assistants, to the National Governors Association piece on best practices and the role of nurse practitioners in increasing access to primary care, the National Association of State Boards of Nursing and that model legislation, a Health Affairs article on nurse practitioners and primary care, and a link to that brief that also resulted from a Robert Wood Johnson Foundation supported activity. Institute of Medicine study on the future of nursing that includes discussion of nurse practitioners, reference to the coverage and payment for nurse practitioners and physician assistants. This is the MedLearn material that follows next. Two items that were not discussed on the call that but are out there, and we want to make sure you're aware of them in the environment. A nurse practitioner's a business practice and legal guide that looks like it's a nice comprehensive overview of some of the that goes into greater detail of some of the issues we discussed on the call today. And then also, some of you may be aware of one who worked with the American Association of Nurse Practitioners and often published in their journal that provided the Pearson report that described tracked the scope of practice on a state level. And then finally, I've included a link to the health lawyers to an overview of the corporate practice of medicine. Okay. A question that's come in, again, this is the opportunity for questions and feedback. We've talked about home health orders electronically, but the amount of orders that are accepting verbal orders from nurse require the physician to sign the order after the fact. Oh, and the comment is that it's how difficult and frustrating it is that little things like blood pressure checks, Coumadin, dose changing, et cetera, also would require signatures. Is there any foreseeable change regarding this? There isn't any that we're aware of at present, but this is something that we'll keep in mind, and it may be the situation that, again, other than on a scope of practice basis on your state, where there may be some signature authority. Again, some of this is maybe state level based, where the changes would be made. But this is something that we will keep in mind, again, as standards are developed that would come along for care transitions and some of the communications that go along to carry those care transitions and the orders, et cetera, and everything that's learned from the patient assessments and has to be followed up on. So again, we appreciate the frustration and the comment, but not aware of anything other than working on the scope of practice issue on the state level. For nurse practitioners, there is the National Governors Association December 2012 paper, and someone did reference and bring to my attention, and I didn't mention it on the call, but there is a new FDC policy paper on nurse practitioners. We'll also post the link to that in terms of the environment and the competitive effects of nurse practitioners and physicians in different communities. So again, appreciate that pickup, and we'll include that in the references. One last question that has come in, and I should have mentioned it on the call. As in the shared savings environments, and as a matter of patient stratification and patient segmentation becomes more and more important in terms of taking care of patients and negotiating arrangements with health plans or working under shared savings environments. The topic of diagnostic coding and hierarchical classification coding, or HCC scoring, comes into play. We will do additional education around those topics. In short, what the ACC system does, it's an insurance-based sort of actuarial projection system that works off the diagnostic codes that reduces the thousands to about 70, and then from that predicts out the cost of care. It's important, what feeds into that is the extensiveness of diagnostic coding. So the reason that's important is that those scores are increasingly going to be driving the compensation and the payment models in the future. So we will provide resources and webinars and material, and have a webinar and post information on the site from prior discussions at annual meetings such as those from Dr. Bruce Kanosian and others. And we'll make sure that those are known to you and available. I'll send that into the listserv and mention that on the e-news, that the understanding of the relationship of the diagnostic systems, including going to ICD-10 and how that impacts on the HCC scoring, will be important to your future success clinically and financially, and to be able to take care of patients and to manage those patients that you have under these arrangements. Thank you for your attendance this afternoon and for the your great feedback and input. Again, we'll post the slides and the references and the materials discussed on today's call. Thank you very much, and hope to see you in a couple months. Bye-bye.